right, welcome everybody to our experience. My name's Chad Wers. I'm the CEO of ASCP alongside Tom Hansel, who is my podcast partner in crime from Hansel Health. And we are doing an episode that we call Leading Not Bleeding. And we've got one of the new young leaders of Pharmacy Association with us. We're very excited. I'm very excited to have Krystaln Weaver on. She is the new executive at NASPA, which is the National, I might get this wrong, Krystaln, just so you know, National Alliance of State Pharmacy Associations. Is that right?
Perfect. A
And
plus.
so, it wasn't very long ago that I started at ASCP 6 years ago, and I was the new association executive. And like in a flash, I went to like the third oldest. So I don't even know if I can share what it's like to be the new person because I wasn't new very long. But you are the newest leader of pharmacy, and you've just made a tremendous impact very quickly. I'm in admiration of your assertiveness and your willingness to stick your neck right into the issues and try to help move this profession forward. So thanks for being on, and thanks for what you've done so far.
My pleasure. Thanks for the invite. Thanks for making the transition a lot easier by being my buddy
Yeah.
around the table.
Well, tell us a little bit about your history. You have a deep history in pharmacy association. So give us the how did you get here answer.
Sure. So, pharmacist by training. I come from a pharmacy family. I think there's 6 pharmacists in my family. 3 others from the University of Toledo in Ohio, where I went to school. And my little brother's there now. I first, out of school, did a residency with APHA. They're called fellowships now, but when I was there, it was a residency in executive management. And loved it. Loved being at APHA. Got a ton of experience and got to meet a lot of really cool pharmacy leaders through that year. And then through there, met Becky Sneed and got to know NASPA, the National Alliance of State Pharmacy Associations, and that ended up being my first job. So I started with NASPA right after the residency ended and headed up the policy shop. I was the second full-time employee, the second pharmacist there, and we built it up and did a lot of great policy work and helping the state pharmacy associations to do their work leaner and more efficiently, and I think better, even better than what they already do. And I was at NASPA for 7 years, ended up going to law school, and did a little sidetrack for a couple years at a law firm, and found my way back to NASPA, now heading things up. Happy to be back.
It's such a great story. There's a lot in there. I want to break that up a little bit. So what made you first of all, you're from Ohio, correct?
Correct.
We got to lead with that. Great people come from the great state of Ohio.
There you go.
So, but what made you deciding to come to DC and do a fellowship or a residency is not for the meek or the unwilling. Like that's a challenge, and we have a fellow here. It's our third version of our executive fellow since I got here. It takes a special person to want to do this. Like, what made you do that coming out of school?
Well, I knew pretty early on that I probably wouldn't be a traditional pharmacist. I loved doing organization work in college. I was student body president at one point, and in all the organizations, didn't go to class enough to be a great clinician. If we're being honest, but loved the organizing and advocating piece of that. And at first thought I might do managed care pharmacy. I liked the population level idea. And then kind of stumbled across association management as a career path. First through the Ohio Pharmacists Association. I did a API rotation with them. And didn't think I had a chance at getting a national residency, to be honest with you. And so I had many backup plans. I did the match. I took the LSAT in case I didn't get any job and needed to go to law school instead. But got lucky and got a spot at APHA. And it was scary to leave Ohio. I'd always lived in a small town and to come to DC. But it was great. I'm very glad that it ended up that way.
Absolutely. Well, once you realize that everybody here wants all of what Ohio you can bring with you, then it makes it a lot easier. Tom,
Well, it wasn't like that before,
yeah,
but it does feel like that now.
So it didn't scare you coming to DC and getting into the politics and seeing kind of
Oh, it
how
definitely
challenging
did.
it was. You mean you dedicated your life to doing it now?
Yeah, yeah, no, it definitely scared me. I mean, just like being in a big city was pretty scary at that point in life. But pharmacy is like a small community. So once I was here, it was fast that I felt like I was part of the family and had people around me who were supportive and became part of my smaller network of close friends and colleagues. And yeah, made it a lot easier.
As far as the legal side, why did you feel compelled that you need to go down that path and also get a law degree?
Well, I thought that I might want to do broader health policy work, and when I was looking at the world, it seemed like you couldn't do broader health policy unless you had a JD after your name, at least in DC. Um, it's a little gatekeeping that happens there. But also, I had always been interested in the law. I mean, I took the LSAT back when I was in pharmacy school still, and wanted to get work experience first. Turns out it's hard to get a job with 2 doctoral degrees and no experience. Like, no one wants to pay for that. So I'm really glad that I waited, and that's the advice I give any pharmacy student who says that they're thinking about law school. Like, work a little. First, make sure that that's really what you want to do, because you really don't know what you want to do with your life, coming straight out of school. And then having a little bit of life experience also made law school, I won't say easier, but more interesting. I think I was a more engaged student because I had lived a little and had some learned experience to bring to the table. So I'm glad things worked out the way they did.
yeah, I mean, I can say from our standpoint, well, from my standpoint, it's brilliant that you have that law degree. I don't have a law degree. I have people around me that we've hired that are either attorneys or have worked on the Hill. There's a different language that you speak that is important language because it's the bridge between somebody like a member saying, "Well, that law is so dumb. Like, why are they doing that? Let's just fix it." Well, it's just not that easy. Like, there's all these laws and rules you have to follow to fix things, and it takes time. But to have somebody in your position that has that acumen is very powerful from my perspective and extraordinarily helpful as we kind of tackle these issues as a profession. Um, so it's been exciting to have you on board. What can you say? You're new-ish. Like when did you start?
January 1.
January 1. Okay, so you've been in place for 4 months. What do you think is the biggest priority as you see it for state pharmacy associations?
So I think if you polled the state associations, it's probably 50-50 split between advancing the practice, clearing the way for pharmacists to do what they do best in terms of clinical care of patients. So enhancing scope, identifying payment opportunities, that being one bucket. And then the other bucket being blocking and tackling on the PBM issues and making sure that pharmacies are able to continue to exist. Um, those two things are the big priorities in all of the states. And which one takes the lead probably depends on the state, depends on the day, depends on what's going on in that state. I think that, we have to make sure that the pharmacies can survive. And so the PBM business issues have to matter. We have to focus on that. But if we don't fix the pharmacy practice side and make sure that pharmacists are able to do what they're trained to do and get paid for it, we may not have a profession in 40 years. Maybe 30 years, maybe 20 years. I don't know. But it certainly could be possible that technology could replace a lot of the functions that pharmacists do today. I don't think that technology, even AI or whatever else, or other health professionals can replace the clinical care that pharmacists are uniquely capable of providing. But we need to make sure that we're planning for the future, not just next year, but 30, 40, 50 years from now.
Yeah, I mean, well said. I mean, I think that
Yeah.
that's what we all face. I don't think that's even, from a state perspective, sure, but from a federal perspective, yes, and from a niche practice, whether it's long-term care or pediatrics or anything else, those are the things that we have to focus on. One is
Yeah.
Yeah.
we're in this weird
We,
oligopathy. I don't even know how to say it. We're in this weird monopolistic situation with PBM,
Yeah.
and it's creating pressure. And we're in this sort of empowering position to be able to show that pharmacists can do more and have done more recently, especially during COVID. And it's both of those issues at once.
well, it's like any industry. You have to evolve. You have to evolve with the times. You have to evolve with the laws, and you have to evolve with the technologies out there. And so we've got two choices. We could, wish it was the way it was, pre PBMs and back in the family town pharmacy, or we can adapt this technology and to continue expanding and diversifying our impact. And I believe a lot of that has to do with, like Chad said, about vaccines, but also on the clinical component. Certainly, there's got to be technologies that can maybe assess what Google says and spit out some kind of formula or spit out some kind of recommendations, and that technology is going to continue to evolve. But I think it takes that critical thinking, and it also takes communicating to the patient, communicating to the prescriber, the nurse, to understand what they're seeing about the patient, to understand what signs and symptoms beyond what maybe tests or labs or numbers can tell you.
Yeah.
Yep, absolutely.
So do you find that message being, since you were back there 7 years ago from the beginning when you started to now, have you seen when you're talking to people on the Hill that people are paying more attention? Is that message getting through? Especially, I know there's a lot of anti-PBM conversation, but just about the scope of pharmacists and expanding that practice. Has that gotten easier, or has that gotten harder for you?
So, just one clarification: I don't go on the Hill. Our members advocate in the state level, and NASPA does not have a advocacy function.
Okay.
We support what the states do and help them do what they do better. I go in a personal
No attorney
capacity.
answer. See that? See that?
There's a disclaimer.
That was right.
Yeah,
That was good. She goes on a book of millennials.
the other disclaimer that I sadly have to make is that I've been out here for a little longer than 7 years. So.
Okay.
Although I wish that was my number.
So have you seen a change? Have you seen the conversations?
I think in two good ways on both of those big issues, the business of pharmacy and the practice advancement side. So on the business of pharmacy side, I mean, from the first times I was talking about PBMs, and it was like my light bulb moment of how the business of pharmacy worked, no one was talking about PBMs. Like, the assumption was pharmacists didn't even really know how PBMs worked or that there were problems, let alone legislators. And now that's not the case. Folks know who PBMs are. They know there's a big problem. Industry has even gotten on board that it's a problem. It's not just independent pharmacy owners and state pharmacy associations and NCPA waving the flag about PBMs. It's everyone in pharmacy. It's legislators. It's pharma. It's everyone except for PBMs realize now that PBMs are a problem and can kind of explain why they're a problem. So that is just a revolutionary change from what I saw when I first started on these issues. On the practice advancement side, I think there's also been a 360 or 180 change from where we were before. When I started talking about pharmacist prescriptive authority, I was not allowed to use the word prescribe. I remember being scolded in a policy-focused meeting. I won't call out what the meeting was or who scolded me, but being scolded for using the word prescribe. Like, don't dare say that. That'll just upset the doctors. I'm like, I don't care who gets upset about that word. That's what we're talking about. And of course, pharmacists should be prescribing and choosing medication therapy. Like, who is more qualified than the professionals who know drugs? Nobody else knows drugs like we do. Not me, but the collective we. So, and now it's just very normal. We're seeing patient groups that aren't even necessarily tied directly to a pharmacy organization advocating for pharmacists to be able to prescribe. No, we want to be able to access drugs directly from pharmacists. We want pharmacists to prescribe these medications. And there are policy think tank organizations that have put out model legislation about pharmacists prescribing and using the word prescribe scandalously, and it's no longer a scandal. So I think that recognition has dramatically changed. Another thing that's changed on that front in a negative way, in my opinion, is that because of all the pressure that's on frontline pharmacists, to do everything faster, leaner, more efficiently with metrics, there's a perception that they don't have time and thus don't want to do these advanced services. And that's a problem, because if we have a win in a state where now they can do a service, but then it never happens, legislators see that it doesn't happen and they don't want to vote for the next win, and progress stalls, or payers don't want to pay for it because pharmacies aren't doing it. So, the business side that's put so many pressures on pharmacy practice and all practice settings has, I think, stunted our growth on the practice advancement side potentially. That's not to say that innovation has slowed in the policy realm. I haven't done an analysis or anything of that to say that that's happened, but I think it certainly makes it harder when we're advocating. And we also have to think of, what about pharmacists who oppose this? How do we counter that message that could end up at a legislator's desk when a pharmacist opposes that we get this advanced authority? So that's really challenging, I think.
Yeah, I think that reminds me of an issue, and then I have a question. But the issue reminds me of is the whole, and I don't want to get too controversial, but like the whole unionization of pharmacists issue. And my concern is the second you advocate for that or you go down that road, you're kind of resigning to the fact that you're a manufacturing worker. That's who unionizes. Like, I get why you want to do it, and I'm sorry we haven't created more solutions to help people not feel like that's the only way to get protections. But I feel like if you go down that road, it sure feels like you're anti-manufacturing of pharmacy, but you're falling into the model of manufacturing of pharmacy. So
Yeah.
that concerns me from that standpoint. But my question, I think, from the standpoint of the states and your work to date, I feel like we see progress in states faster, certainly, than we see it at the federal level. I asked this question to a leading sort of anti PBM person, and they didn't have a great answer. But I'm going to ask you this question. So, what do you see in the states? There's been some recent legislation in the states, but what do you see states doing that looks like a potential win for all the states, all of pharmacy, from either a reimbursement perspective or fighting back against the PBM perspective?
So, two things. I don't know that they're translatable to the federal level. Well, one of them is, one of them probably is not. One is accountability and regulating PBMs to make sure they're regulated in the same way that every other component of the healthcare industry is regulated. So they can't be imposing these abusive policies on pharmacies about audits and under reimbursing and failing to follow through on their contracts for disputes and all of that. And so, that's hard. It's not just getting the legislation passed to regulate them, it's also having the state actually do the regulating. So it's a long, difficult battle. It's not just an easy win in the states. I think that's one avenue. Another is changing the reimbursement model. So it's NADAC plus cost. NADAC plus the cost of dispensing, a dispensing fee. I think that there's a lot of evidence that is better for pharmacy. It's more fair, it's more realistic, and states save money if you pair it with no spread pricing for PBMs. But it's hard. It's a whack-a-mole game.
That's kind of what I see too. But like, and there are some states that have done that. So there'll be some real world evidence of what does that look like from a state perspective. And then I think your first one is right on. I mean, we just have lived through the Change Healthcare cyber attack problem, and you were on all those calls. I was. It was kind of easy at first to feel bad for them because they looked so contrite on the phone with what happened to them. Which I don't know if that was sincerity or if that was being concerned that the other shoe was going to drop, which was, hey, you're supposed to have procedures to protect against this. You're supposed to follow the conditions of participation for Medicare Part D, which says your systems have to be up in 72 hours. And they weren't. And who's going to hold them accountable for that? So the accountability thing, I think, is a big one because that I feel like we can extend further. Hey, CMS, not only do you have to hold these plans accountable for having disaster plans that are real and that they can actually execute, but also there's other provisions in that conditions of participation, like reasonable reimbursement, that you also allow them to ignore, and you don't have any teeth in those conditions. So there is some federal government emphasis that we can make that you can help shape this. You can't, there's non-interference. You can't tell people what to pay, but you can help shape this in a way that's better for pharmacy.
Yeah. It's hard. I mean, there's states that have had wins over the last 10, 15, 20 years, and things aren't great in those
No,
states. It's not like there's been a big, like, this is the way moment that we've had. I mean, we keep working towards that, and states, Washington State's had a big win this year. There's many states that have had successes, but it's all part of the implementation and the other ways that PBMs find
yeah,
ways
whack
to
a
squeeze
good
money.
example, like good analogy. It's whack-a-mole. It's watching them find the loophole in the new legislation that's supposed to help fix things. It's just a continuous, battle.
So how do
And
you
that's why I
find
think
wins?
we have to keep the practice advancement in
Yeah,
sight. Sorry, Tom.
yeah.
No, it's right in line with that. How do you find wins personally and with your organization, knowing that you've got some very lofty goals that could take decades and to really come to full fruition? How do you continue finding wins in what you're doing to keep you guys focused and on track?
Well, at NASPA, we try to look at we have the privilege of looking across the states and seeing what's worked well and finding messages that resonate and finding the newest innovative model that we can share with the other state associations to try to work towards, if they can't achieve the big practice advancement win right away, to work towards and take steps towards a common goal. And so, it's over the last 10 years, it's been prescriptive authority, and that has just completely ballooned in the states. I mean, when I started tracking it, it was just California with their couple statewide protocols. But that grew to every state having some kind of way for patients to access naloxone, every state having collaborative practice authority, which I think has held us down more than it's helped us advance at this point. But an option for pharmacists to do something in states that don't have broader prescriptive authority, to several states now having broad prescriptive authority for pharmacists, that as long as there's a diagnosis or there's a condition that's easy to diagnose, or some kind of medication that doesn't require a diagnosis, like preventive care, pharmacists can prescribe without asking a doctor to pretty please let me do it. Uh,
Yeah,
Almost, doing what we were trained to do.
Right.
I have a friend who does pharmacy in London, and I know it's a one payer system over there, but pharmacists are setting up really kind of mini Walmarts, and they're actually renting out their space to chiropractors and holistic therapists and infusion therapists and those type of things, and then they're able to prescribe basic sinusitis and birth control and those type of lower acute uh, type of needs, and be able to diagnose and prescribe those. And it is a different payer system. But to me, with the senior population growing, there's so many rural areas, and the doctors, prescribers actually, having some shortage of their own, nursing having shortage that was going to be pretty severe. I think it's really the only way that we're going to properly be able to take care of people across the nation, especially in rural areas. Um, who's fighting the most, I guess, against that? Is it the American Medical Association? It's mostly the doctors. And what is their reason for fighting that? They really can't. There's really not enough of them to take care of the needs as it is now.
Yeah, it's absolutely the medical societies in every state. Sometimes we get pushback from payers because they think it's going to increase their costs, but the loudest voices are absolutely the medical societies. And the weird thing is that it's not the frontline doctors that oppose it. In every state, there's always, constant stories that frontline physicians who actually care for patients and actually work with pharmacists love working with their pharmacists and even will advocate for pharmacist authorities in many states, which is a great tactic to use to combat the medical establishment arguments. But the AMA has policy on the books that says they oppose scope expansion by other providers.
Do you know why?
And
Is it just self-preservation, or do they, is it focused just on that?
yeah, it's just a turf war. It's protectionism, probably passed by doctors who owned their own practices back when that used to be a thing, and those were the active voices in the House of Delegates of the AMA that one year, and they passed the policy. And the AMA collectively has just really dug in, and they expect their state societies to do the same thing, and they're good at it. They've got a lot of money. There's a lot of doctors in state legislatures because it's expensive to run for office and doctors have money. And so they're a very influential crowd. And it's a big problem. I personally think that a strategy we need to use more is to team up with other non physician providers. There's a group of non physician providers that used to be very active pre COVID that I was part of back then that's gone a little quiet, but I'm hoping we can rejuvenate that conversation, and use our collective power to help everyone advance. But that takes a little swallowing of our own egos because things pop up in different states, and the instinct is to say no. Physician assistants shouldn't do that, or no, dentists shouldn't do that. That's what pharmacists do. So we have to be careful that we don't do the same thing that doctors do when you see, legislation about dentists giving flu shots. No, they can do that. It's not that hard. We can train dentists to do flu shots. And actually, that's a pretty good idea if we want to increase flu rates. So we have to resist our own protectionist tendencies in order for that kind of collective work to work. But I think we could make it happen. So I think it's something we should think more
I
about.
also think we have physician groups that are not, not the AMA, that a lot of us work with. We work with the American Medical Directors Association, or the Society of Post Acute Long Term Care, which I think is their new name or what they call themselves now. But they're very pro pharmacists. They sign on our letters.
Yep.
But I think you're right. It's kind of isolating some of the antiquated medical associations. It's also AMA. You like that? Anyway,
Yeah.
uh, isolating some of those AMA type uh, organizations and moving past them. I feel like COVID did, as tragic and difficult as that time frame was, pharmacists were pharmacists during that time frame, and they did what we would expect pharmacists to do. They stayed open. They, at least in our world, they picked up new responsibilities like vaccination, and they ran into the burning building. While, sorry, the physician's office is closed and didn't let anybody
Yep.
in. Um, I feel like that is recognized by the public and so far by the legislators. And I think we're past that sort of, at least with the ECAPS bill, I think we're past the um, credibility of a group like AMA being against it. We'll see. That was going to be my next question was, put your prognosticator hat on. Does ECAPS pass at the end of 2024?
I would love to see that. I really would be so, so happy to see
Put a
that.
number on it.
Uh,
Put a percentage.
my project when I was the resident at APHA was when the first, modern provider status bill was being formulated. My project was to manage the internal committee at APHA during all those great brainstorming, strategic planning kind of sessions of how we were going to do it. So I feel like that's how I was brought up in the association world, was with our federal provider status. And I so many times that I thought it has to pass. I don't see how it passes in 2024 personally.
Oh my gosh.
If I could put a number on it, is low, but I'm not a federal lobbyist. You don't want to ask me. I'm a little beaten down over the last, 11 years that we've been trying. So I'm not super positive on it personally, but there is no step that I would not take to try anyways. So every time there's a call to action, I will act and encourage others to do the same. But
A low percentage.
it's a low.
I mean, you're more engaged than I am by background. I really feel like there's a shot. I wouldn't put it low, but I don't feel like I'm as educated on the process as you are. So it makes me feel bad that you don't think it's got a chance.
Well, it makes me feel better that you think it has a chance because you've been more engaged in more recent years.
Yeah, I mean, it's got a lot of support. I mean, it has a lot of co-signers.
We once had over half of both the House and Senate as
And
co-signers.
we're getting
And
there
that didn't
again.
do it.
And so I can see that. Like that's not the end all be all if you have all those support. But I think it depends on the score. And I just really lean on the fact that, I mean, this is a window that we're not going to have open very long as it relates to the COVID emergency.
Yeah.
If people haven't forgotten already what that was like and the way pharmacists reacted, they certainly are going to forget in the next couple of years. So this is it. Like,
Yeah.
it's a lame duck year. It's a presidential election year. People on their way out could vote for something that they're not worried about getting kicked out of office over.
True.
I think the score is going to be the biggest plus minus. If it comes in at a reasonable 10-year cost, if they somehow allow dynamic scoring, which I heard on a call a few weeks ago was possible, then I think it's got a chance. But we'll know that in June, so we'll know shortly.
Right.
I mean, I think we have to do everything we can collectively to talk the same talk. I know that many of the pharmacy associations are much better at being on message together for the most part. So
I agree. I think there's better unity across the national associations than there's ever been before. So I think that is a big check in our favor.
For sure. Well, I'll speak for ASCP. We are a small national association. We do not have resources to dig into state issues. Occasionally, if it's a big issue in a big state, we apply some resources. So we rely very heavily on you and your members to help us in some of those places, and are grateful to have a good partner in NASPA and a good leader in you being there. So we had a great relationship with Becky. It's going to be fun working on things going forward with you as well.
Likewise. And we super appreciate the expertise that you have. We don't have long-term care consulting pharmacists expertise. And so when things come up in the States that we can turn to you, that's super valuable, and really appreciate that.
And I'm just happy because Chad originally said we're going to talk to someone from NASA. So I thought we we're going to have to talk about the eclipse and everything. And so just to find out this pharmacy, I always get prepared for that. But no, thank you for fighting the good fight for us. We appreciate it. We certainly want to support you all and everything you're doing, because we're in this together.
Absolutely.
Yeah.
And I look forward to coming on to talk about the eclipse next time, because I loved it.
And we do a lot. We do a lot with some of your members. We continue to try to work with any of the states that are willing. we have a number of relationships with states from a membership perspective and from a meetings perspective, and it's great to be able to work with like-minded pharmacists all over the country. So thank you for that.
Absolutely.
Thanks for being on the
Like,
podcast. And,
my pleasure.
I'm
Thanks
sure
for
we'll
inviting me.
invite you back on some big issue that we're dealing with in the coming months and years. So appreciate it.
I mean, hopefully it's to like celebrate ECAPS
That would be
passing at the
great.
end of the
We can even play these clips of where we put the odds, and then so. Thanks so much, and thanks everybody for listening to this version of our experience. And we'll see you next time.